Good morning. For teaching rounds today, I've prepared a clinical explainer that perfectly illustrates the complex intersection of end-stage liver disease, pulmonary complications, and the road to transplant. I want to present a patient who forces us to carefully navigate a new hepatocellular carcinoma right alongside profound hypoxemia, and it really requires us to deeply understand the underlying physiology driving his decompensation. We'll structure this case into 4 distinct acts today, starting with his admission, moving into a pathophysiology deep dive, discussing our word management, and wrapping up with disposition and some key teaching pearls. Let's jump right into Act 1 and meet our patient, Mr. R, who presented a pretty fascinating diagnostic challenge for us yesterday. To give you his background, Mr. R is a 58-year-old male. His primary diagnosis is cirrhosis, originally driven by hepatitis C, which is now cured with a sustained virologic response, and alcohol use disorder, for which he's been abstinent for 14 months now. But despite his abstinence and the viral cure, his current baseline MELD score is 16. This is clinically significant because it shows us he's got irreversible architectural changes in his liver parenchyma that persist even though the inciting insults are gone. He also has type 2 diabetes and is a former smoker with a 25-pack-year history. His outpatient med list is pretty standard for decompensated cirrhosis: carvedilol for portal hypertension, furosemide and spironolactone for ascites, and insulin glargine. Now, he originally came in for what was supposed to be a routine visit, but the single line in his chart that really dictated our entire workup today is that his 6-month surveillance ultrasound is currently 11 months old. He slipped through the cracks, and he is heavily overdue. Aside from the missed scan, his primary acute complaint is a progressive, debilitating breathlessness over the last 3 months. Just walking to the mailbox forces him to stop. But notice the specific clinical pattern here. He reports his dyspnea predictably worsens when sitting or standing and actually improves when he lies flat. I want to pause on that positional direction because it's the exact opposite of heart failure, right? In heart failure, venous return increases when the patient is supine, flooding the pulmonary circulation and causing orthopnea. Here, lying flat improves his saturation. That single clue completely pivots our differential away from cardiac volume overload. He's got absolutely no paroxysmal nocturnal dyspnea, no fever, no chest pain, and no melena. On physical exam, we noted distinct clubbing of the fingers and multiple spider angiomas across his upper chest. Classic stigmata of chronic liver disease for sure, but also prime indicators of profound vasodilation. His lungs are completely clear to auscultation, and his admission chest X-ray is entirely normal. We grabbed a room air arterial blood gas while he was seated, which showed a PO2 of 62 millimeters of mercury and a widened AA gradient of 34. Clinically, his oxygen saturation is 96% when lying flat, but the moment he sits up, it rapidly falls to 89%. Moving into Act 2, let's unpack these pulmonary complications and derive his unique symptoms directly from his portal hypertension. Let's meticulously build the pathophysiological chain for what he's experiencing: hepatopulmonary syndrome. It all starts with advanced liver disease and portal hypertension. The failing liver either fails to clear vasodilators like nitric oxide or actively stimulates their production. This triggers the opening of massive intrapulmonary vascular dilatations. Think about the physics of the diffusion barrier here. Normally, a pulmonary capillary is incredibly narrow, forcing red blood cells to pass in single file, pressed right up against the alveolar membrane for immediate gas exchange. But in hepatopulmonary syndrome, these vessels dilate massively, anywhere from 15 to 500 micrometers. Because the vessel is so wide, the red blood cells cluster and stream rapidly right through the center of the vessel. They literally pass too far away from the alveolus for the oxygen molecule to physically diffuse across the plasma and reach the hemoglobin. This creates a functional diffusion limitation, leading to that widened AA gradient and profound hypoxemia. However, because this is a diffusion barrier and not a fixed anatomic right-to-left shunt like a hole in the heart, it still corrects with supplemental oxygen. Flooding the alveoli with 100% oxygen increases the driving pressure just enough to push oxygen across that widened plasma gap. So why does his oxygenation crash when he sits up? Gravity. These dilatations predominantly form in the bases of the lungs. When he sits or stands, gravity forcefully pushes pulmonary blood flow down into those basal regions. More blood pooling in dilated dysfunctional vessels means vastly worse gas exchange. This creates platypnea, the subjective shortness of breath when sitting, and orthodoxia, the objective desaturation when sitting. By definition, we confirm this with liver disease, an AA gradient of 15 or more, or a PO2 below 80 along with objective evidence of those intrapulmonary dilatations. To prove these dilatations exist in our patient, we ordered a contrast echocardiogram, a bubble study. I always view the contrast echo as a strict timing test. We inject agitated saline into a peripheral vein, creating microbubbles that travel to the right heart. If bubbles appear in the left atrium within the first 3 cardiac cycles, we're looking at an intracardiac shunt, like a PFO or an ASD. The transit is practically immediate. But if they appear late, between 3 to 6 cycles after reaching the right atrium, that delay represents the exact time it took for the bubbles to exit the right heart, traverse the dilated pulmonary capillary bed, and return to the left side. Mr. R shunted at exactly 4 cycles, which definitively confirms the dilatations of hepatopulmonary syndrome.
Now we have to explicitly force a contrast between his condition and the other major pulmonary complication of cirrhosis, portopulmonary hypertension. Imagine a completely different patient next door, a 46-year-old woman with MASH cirrhosis. She complains of exertional dyspnea, but has absolutely zero positional change. Lying flat, sitting up, it makes no difference. On physical exam, she has a loud P2 and elevated JVP. Her oxygen saturation is a perfect 97% in every position, but her echocardiogram shows a right ventricular systolic pressure of 62. This represents a totally different pathophysiological mechanism. In Mr. R's hepatopulmonary syndrome, the vessels pathologically dilate, causing an oxygenation problem. In her portopulmonary hypertension, the vessels pathologically constrict, causing a profound pressure problem.
Instead of vasodilators, portopulmonary hypertension is driven by a dangerous rise in circulating vasoconstrictors, primarily endothelin-1, which escape hepatic clearance and hit the pulmonary circulation. This causes immense vasoconstriction, smooth muscle proliferation, and permanent remodeling of the pulmonary arteries. The primary defect here is right ventricular afterload, which is why her systemic saturations remain totally normal until end-stage right heart failure finally kicks in. We confirm that diagnosis with right heart catheterization. Unlike our patient, portopulmonary hypertension requires aggressive pulmonary arterial hypertension therapies. We'd use prostacyclin analogs to force vasodilation, endothelin receptor antagonists to block the remodeling, and phosphodiesterase 5 inhibitors like sildenafil to increase cGMP. Because this is a pressure-driven disease of constricted arteries, giving supplemental oxygen does very little to alter the underlying hemodynamics. Okay, moving into Act 3, let's look at our assessment and ward management, starting with that heavily overdue ultrasounds. 6. This number is non-negotiable. The surveillance protocol demands an ultrasound with or without an alpha-fetoprotein level every 6 months, indefinitely, for every patient with cirrhosis. The physiological reason for the strict interval is based on the known tumor doubling times for hepatocellular carcinoma, which is roughly 3 to 6 months. Because we let his surveillance slip to 11 months, we unfortunately found the cancer you always have to assume is growing. We ordered a multi-phase MRI, which revealed a 2.4 centimeter lesion in segment 7. The imaging shows intense arterial hyperenhancement followed by washout in the portal venous phase. My rationale here is rooted in hemodynamics. Hepatalia cellular carcinoma primarily derives its blood supply from the hepatic artery, whereas the rest of the liver relies heavily on the portal vein. So, in the arterial phase, the tumor aggressively lights up with contrast. Then, during the venous phase, the contrast washes out of the tumor while the surrounding normal parenchyma enhances. That specific hemodynamic pattern in a cirrhotic liver is entirely diagnostic. Absolutely no biopsy is required, which brilliantly avoids the risk of tumor seeding or bleeding. His AFP came back at 68. We must always contextualize this risk. The baseline risk of developing hepatocellular carcinoma and cirrhosis of any cause is 1 to 6% per year. But with his history of chronic viral hepatitis C, that incidence jumps to 3 to 8% per year. Plus, the risk is heavily amplified by concurrent alcohol use, obesity-related MASH, hereditary hemochromatosis, diabetes, and tobacco. Mr. R has 4 of those 6 major multipliers. His risk was massively amplified, and the cancer just announced itself silently. While this new cancer dictates his long-term urgency, for his acute hepatopulmonary syndrome, we'll walk the treatment ladder on the ward. We provide supportive oxygen to overcome the diffusion barrier. We could consider embolization if a CT angiogram showed one specific massive abnormal vessel, or TIPS in very highly selected patients. But honestly, there is no medical therapy, no pill or infusion that successfully reverses those diffuse dilatations. The only definitive treatment to correct his hypoxemia is a new liver. A crucial point for our acute ward management is understanding his balanced coagulopathy. Cirrhosis is a rebalanced hemostatic system, not an inherently bleeding one. Yes, pushing toward bleeding, we have reduced hepatic synthesis of clotting factors, low platelets, and hyperfibrinolysis. But pushing back with equal, if not greater force toward clotting, we have reduced protein CNS, deficient profibrinolytic factors, and highly elevated von Willebrand factor. these patients still form devastating clots, including portal vein thrombosis. So I want to emphasize that the PT and INR in cirrhosis measure synthetic function, specifically reflecting the short half-life of factor VII. They do not accurately measure bleeding risk. Therefore, we must stop reflex transfusions. There is absolutely no physiologic support for ordering routine plasma, platelets, or cryoprecipitate just to correct a lab number in a non-bleeding patient, unless they are in overt DIC. Furthermore, our ward management requires strict adherence to specific dietary and medication protocols. First, we need to completely retire the outdated, harmful practice of protein restriction. We must feed him properly to fight severe malnutrition and sarcopenia, setting protein targets at 1.2 to 1.5 grams per kilogram per day. For medications, acetaminophen is allowed for pain but strictly capped at 2 grams per day to prevent overwhelming his already depleted glutathione stores. Aspirin and NSAIDs are to be avoided entirely. NSAIDs inhibit renal prostaglandins, which a cirrhotic patient desperately relies on to maintain renal perfusion, and they can rapidly precipitate acute kidney injury. Aminoglycosides are strictly contraindicated due to an exceptionally high risk of acute tubular necrosis. Finally, before discharge, we will update all his vaccines as superimposed infections are primary trigger for acute on chronic liver failure. Which brings us to Act 4, disposition, teaching pearls, and the road to transplant. 15. As we know, the MELD score calculates 90-day mortality. A MELD score of 15 or higher is the evidence-based threshold to definitively trigger a transplant evaluation. At a MELD of 15, the mortality risk of remaining on the wait list finally intersects and surpasses the mortality risk of the transplant surgery itself. Mr. R actually has 3 separate indications to be referred to the transplant center today. First, his biological MELD is 16. Second, he has a new hepatocellular carcinoma. His single 2.4 centimeter cancer falls neatly inside the Milan criteria, which mandates no single lesion over 5 centimeters or up to 3 lesions, with the largest being 3 centimeters or less. Because he meets this criteria, he's granted exception points to boost his priority. Third, the system also grants exception points for hepatopulmonary syndrome, recognizing a severe mortality risk that the standard MELD calculation completely fails to capture. Before we formally list him, we ruled out absolute contraindications: inadequate social support, active substance abuse with persistent noncompliance, active sepsis, advanced cardiopulmonary disease, and extrahepatic cancer. And it's a great teaching point to remember what modern medicine has removed from this list. Well-controlled HIV is absolutely not a barrier anymore. At experience centers, we have to stay honest with the patient about the reality of transplantation. We're trading liver failure for a lifelong commitment to intensive immunosuppression, which brings complex trade-offs like calcineurin inhibitor nephrotoxicity, high rates of metabolic syndrome, and autoimmune recurrence in 10 to 30% of cases. But the outcomes are staggering. For patients like Mr. R, we are buying up to 90% survival at 1 year and up to 80% survival at 5 years. As we wrap up rounds, I want the team to take away these major clinical pitfalls. Never let that crucial 6-month surveillance clock slip. Never casually call a cirrhotic patient's dyspnea deconditioning without checking their oxygen saturations both sitting and lying flat. Do not confuse the dilatation of hepatopulmonary syndrome with a constriction of portopulmonary hypertension. Stop transfusing plasma just to fix a lab number. Stop restricting protein, and never wait for the MELD to climb excessively before initiating the transplant referral. So I leave the team with this final clinical thought. The next time a cirrhotic patient tells you they are breathless on the ward, will you remember the physiology and check their oxygen while they're sitting up? Because for patients like Mr. R, missing that window or missing that 6-month scan due to a lapse in follow-up can quite literally be the difference between a curative transplant and a terminal diagnosis. Thank you. I'm ready for any questions.